Hello, everyone, and welcome to tonight's Regis College President's Lecture Series on health. As Dr. Glenn just mentioned, I'm Dr. Kate Edney. I'm your Associate Provost for Institutional Assessment, Accreditation, and Research. Tonight, I'm pleased to welcome, we have, I think, over 50 people in the room right now, and probably maybe a few more who are finding their way to this event of nurses, nursing faculty, social workers, undergraduate and graduate students from a variety of our health professions, and the public who have registered for tonight's event. We're incredibly fortunate to have three prestigious speakers who are knowledgeable on tonight's subject matter and incredibly committed to the work. Tonight, we're going to address the role of artificial intelligence in healthcare. And generative artificial intelligence, or Gen AI, is a burning issue across all industries, education and healthcare especially. And Gen AI has been characterized as both a welcome and as an unwelcome disruptor of how we create knowledge. This technology and how we interact with it is literally changing every day. So what we know about Gen AI tonight might not be quite what we know about it tomorrow. But I'm very grateful for this important discussion, and I'm excited to hear tonight's speakers. But before I introduce the panelists, we have a few housekeeping items to attend to. So I'll give the introductions just after this housekeeping moment. As you can see on the slide, first, to receive contact hours or class credit for attending this evening, you must stay until the end, which includes the question and answer period. For CEU or class credit, you must click on the link to the evaluation survey that will be posted in the chat box at the end of the question and answer period. You must include your name. Students, you must also include the name of your faculty. And most important, you must complete the evaluation form and submit it. So what can you expect and when? Your CEU certificates will be emailed to RNs in 7 to 10 business days. Students, you don't receive evidence of having attended. Your faculty will be sent a list of students who attended. If you're not requesting contact hours or class credit, you will, we hope still that you'll fill out the evaluation form, as we really do use your feedback, and you'll help us to select future topics. The evaluation link will be posted in the chat at the end of the program, and it remains there until 9 p.m., so make sure you copy it, and the evaluation will close at 10 p.m. A few other quick reminders. All attendees have been muted, and we ask that you remain muted with video turned off throughout the lecture. At any time during the program, you're welcome to submit questions directly to everyone in the chat. The Q&A session will begin with a sort of conversation among the speakers and sort of a Q&A amongst themselves, and then it will be opened up to all attendees. During this final Q&A session, we ask that, again, you post your questions directly to everyone in the chat, but if you're feeling a little shy, you can also post it directly to me in the chat, and if you don't want to be attributed, I can say that, or I can just say someone in the audience has asked, or I can give your name depending on how comfortable you are. And then during the last 10 minutes of the Q&A, you may also ask questions in person or vocally by raising your hand. If you're called on, don't forget to unmute yourself. We've all fallen into that trap. And now, before I use too much time for these announcements, the panelists and I need to get to know you, the audience, a bit more, and then you'll get a chance to know our speakers. So I believe Penny has a poll that she was going to administer, or has that changed?
Well, I am going to administer the poll, but after talking with Dr. Landman, we decided, and Dr. Schoenbaum, we decided to do it just before Dr. Landman starts.
Excellent. Okay. So I will introduce our tonight's panelists then. That's what happens when I get stuck in a Zoom loop myself. So our first speaker this morning is Adam Landman, MD. He's Vice President, Chief Information Officer, Digital Innovation Officer at Brigham and Women's Hospital. He's also Associate Professor of Emergency Medicine at Harvard Medical School and an attending emergency physician at Brigham and Women's Hospital. He is an expert in health information technology and digital health design, development, and implementation. In his current role, he is responsible for technology solution delivery and support across all Mass General Brigham hospitals and practices. He works collaboratively to design and implement the future digital strategy, and such that frontline needs for new digital capabilities are met and emerging technologies are considered while support is delivered highly effectively and efficiently. Dr. Landman received his medical degree from Rutgers Robert Wood Johnson Medical School and trained in emergency medicine at UCLA Medical Center. He was a Robert Wood Johnson Foundation clinical scholar at Yale University, where he also received his Master of Health Sciences. He has also completed graduate degrees in information systems and healthcare policy and management at Carnegie Mellon University. In whatever spare time, and he doesn't really seem to have much of it, he publishes in peer-reviewed journals as well as speaks at national and international conferences. And tonight he has generously given his time to present to us the 10,000-foot view of AI and AI in the future. And our second speaker is Anna Schoenberg, DNP, Vice President of Applications and Digital Health at Penn Medicine, driving the transformation of the health ecosystem for advanced health, equity, and clinical wellness throughout digital solutions. Dr. Schoenbaum has been instrumental in integrating healthcare information technology in establishing standards at local and national levels. Beyond her executive role, she actively contributes to the field by serving on the HIMSS Nursing Informatics Committee, co-chairing their Nursing Informatics Innovation Committee and the Maryland HIMSS Board of Directors. Additionally, she teaches at the University of Maryland School of Nursing Informatics program and is a participant in the ANA Precision Health Work Group. Her outstanding contributions in healthcare were recognized with the prestigious 2023 HIMSS and ANA Changemaker Nursing Informatics Award. Anna earned her doctorate in nurse practice and Master of Science in Informatics at the University of Maryland School of Nursing. And we're very fortunate in having her speak to us this evening on AI and healthcare, the bright side. And our final speaker is Catherine Goodman, who is, or Katie, as she is also known, who's an assistant professor in epidemiology and public health at the University of Maryland School of Medicine. She is also an attorney, having earned her JD from Columbia University School of Law and her PhD in epidemiology from Johns Hopkins Bloomberg School of Public Health. She has several areas of research interest, but those most relevant to tonight include her interest in gram-negative antimicrobial, oh, I knew I was going to mess that word up, antimicrobial resistance in inpatient settings. She also looks at the development of evidence-based healthcare epidemiology and antimicrobial stewardship policies, and applying machine learning and other prediction model approaches to healthcare epidemiology questions using big data. And lastly, an increasing component of her work encompasses the use of large claims databases and the application of novel machine learning and informatic techniques, primarily natural language processing, to electronic health record data. Currently, with collaborators across the School of Medicine and the School of Law, she has ongoing work focused on the equitable and legal allocation of scarce medical resources during public health emergencies, and on the legal regulation of clinical algorithms and emerging AI technologies. Given her areas of interest and expertise, we are very fortunate to have her enlighten us as to AI in healthcare, the shadows. I will now turn all of this over to our first speaker, Dr. Landman.
Well, first we're going to do the poll.
Oh,
yeah, that's all right. That's my fault.
That's all right. No.
And this is hopefully that I can go straight to my polls. Yes. And I practiced this today. And this
You did it. It's up.
Okay, good. So everybody should be able to see it. And to go ahead and should be able to answer the questions, correct?
Uh-huh.
Are people answering it?
There are some people answering.
Oh,
Yep,
good.
it's
Okay,
going
now
now. People are doing the thing now.
Yeah, now don't be afraid, because this is not a quiz. This is a poll to sort of get a sense of, the sophistication of the audience. And this is really interesting.
Yep. And it's clear people are taking some time to read through the questions and think about them.
and think about them, which they don't really have to do. But we will get a sense. I'm going to give it a little more time. Nobody's being graded on this.
But still, we have a thoughtful audience, but maybe give them 30 more seconds.
Okay. The important thing here too is that our speakers are getting to see this and will have a sense of what their audience knows or doesn't know. And it's anonymous. What do you think, Kate? Is that enough time?
Well, it's a very interesting skewing. We have about I don't know, more than 70% of the people here have done the first 3 questions, and then the last 2, we have a bit of a lag. So I think there is a little bit of folks reading happening right now, but I think
All right, well,
we're probably good to go.
all right. Okay. So, the results are all here, and now I have to put my glasses on to read these. Okay. So Dr. Landman gets to hear this, and I had to write the answers down to be sure. Okay. So believe it or not, the very first question, let's go all the way up here. We have 56% said it's true, and that in fact is the answer. One type of AI can actually predict future events, and you'll learn about that tonight, or at least 44% of you will. The second question, to further advance AI in healthcare, FDA approval is needed. I probably should have put is sometimes needed, but that is actually true. And we have 46% that said true. The third question, ambient digital technology limits the provider's ability to focus fully on conversation with patients. And that in fact, this is question number 3, that is false. Because in fact, it does enhance it, the conversation. And you'll learn more about that tonight as well. And we had 61% who thought that was true. AI is accelerating drug discovery and development because it can predict drug efficacy and toxicity, and that is absolutely true, and that's 78% of you. And the last one, electronic health record information summarization, extraction can generate incorrect interpretations about a patient's history. And 91% of you were right on target there. So that gives us a sense of the audience, and I can get rid of that now. And that was interesting. That's very interesting. And I think we've got a lot, all of us have a lot we can learn this evening, and I'm going to turn it over to Dr. Landman. I'll stop sharing my screen.
All right. For Kate, thank you so much for the really kind introduction. And Penny, thank you so much for the invitation to participate. Really honored to join this series and to be able to work with Anna and Katie. I think we've got an interesting evening, and I think we're gonna all learn something new. And so I'm going to hopefully you guys are seeing my slides. Just give me a shout if you're not seeing or hearing, or if the slides are not advancing. I am going to give a quick primer on introduction to AI, and specifically generative AI. Some of you may know this, and I promise to move quickly through this, but I wanted to make sure we kind of get everybody to the same level. Then I'll talk a little bit about the promise of AI in healthcare, and then go through 2 potential use cases, or 2 actual use cases that we're piloting. And then Anna Schoenbaum and I are going to kind of work together on this. Anna's going to share some of her results using some similar use cases and her experiences at Penn. And then we're actually going to do a demonstration of ambient clinical documentation. So we've got a lot in store for this first part. But first, I wanted to just talk about digital transformation. When we think about healthcare right now, how do most of us interact with healthcare? Well, when we need to see our provider, we tend to pick up the phone and call them. And often we're put on hold for long periods of time. Sometimes we're transferred to multiple places. Sometimes we get hung up on. Then when you finally do get an appointment and you show up to your appointment, many times you have to sign in on a piece of paper. Sometimes you're handed a stack of papers to fill out that are asking questions that are already in your electronic medical record. And I think that may be a common experience for many across the United States. But if we compare that with other industries like banking, for banking, like I don't even need to go to a bank anymore, right? With the mobile app that you're seeing in the top right, now I can deposit checks, but simply by taking a picture of them. And in fact, I very rarely even need to go to the ATM because you can now pay for things with Apple Pay and Google Pay and Samsung Pay. And so banking has really been transformed and is quite electronic. Even pizza delivery, Domino's, is quite digital now, right? When you want to order a pizza, you go online and you put your order in and then you pay electronically. And you can even track your delivery with this cool app in the bottom right that Domino's has built that kind of tells you exactly where your delivery is. And so other industries are moving fast to adopt digital tools and technologies, and there's a massive opportunity in healthcare. But at the same time, we are really at a crossroads in healthcare in the United States. There are unprecedented financial pressures on our healthcare delivery organizations. I've been, in healthcare for a long time, and I've never seen a climate like this, where so many organizations are struggling to even break even or have a little bit of margin. We have also seen unprecedented levels of worker burnout, and our clinicians, our nurses, our doctors, our respiratory therapists actually leaving the profession, right? They had a very challenging time during COVID, and it has continued to be a challenging time with high administrative burden and high amounts of burnout. And then finally, many are frustrated because it's very hard to get an appointment with a provider. It can be months to get a primary care or specialist appointment. So we have massive challenges that we're all facing. And I do want to acknowledge and thank many of you that have joined today's session. Many of you are already frontline workers and training to be frontline workers. And so just a huge thanks for what you do every day and for taking time from your evening to participate in this session. But it's sort of not all bad news. And what gets me excited is that these challenges in healthcare are a reason that we need digital transformation. We need to use technologies to help supplement our workforce and to provide more automation so that our clinicians can truly focus on patient care. And so there's a really exciting opportunity, and that's what kind of gets me up and going every day. So I'm now going to kind of segue into some of the basics of AI and generative AI. Then I thought I would just start with the definition, just to level set all of us. And a high-level definition of AI are algorithms that perform tasks that are typically require human intelligence. So things like learning, reasoning, perception, and decision-making. And AI is actually a collection of algorithms and computational techniques. So you may hear terms tossed around like machine learning, deep learning, computer vision, heuristic techniques. These are all different forms of artificial intelligence. And for any particular solution, you could use one of these computational techniques, or you can put multiple techniques together to get a solution. And as we go through and share some of the examples, we'll share how these techniques are being used. There are two types of artificial intelligence. The first type is called analytical AI, and this has been around for over 30 years. And analytical AI are algorithms that analyze large data sets, and those algorithms reveal novel insights. So those algorithms are classifying, predicting, recognizing. Those are the types of functions these algorithms are doing. And an example is what you're seeing at the bottom of the screen. this is an example of a convolutional neural network. So that's one of those computational techniques. That's a sort of computational technique, a type of AI. It's an analytical technique. And what these algorithms are able to do is, as you can see, the images are from a colonoscopy. The AI is actually identifying where possible polyps are. So the AI is drawing that green outline around the possible polyps. And you can imagine this could be very helpful for gastroenterologists that are performing endoscopies, so that they don't miss any polyps and make sure that they are doing appropriate biopsies or other appropriate treatments. And eventually, you might even imagine a world as the AI gets better and better and robotics get better and better. This is not current state, but you could imagine the future where you could have a robot actually performing colonoscopies and biopsies. So this is important type of AI and an example of analytical AI. And I want to contrast that with generative AI. Generative AI is kind of all the rage. This has sort of been in the mainstream for about 2 years now, and a little more than 3 years in the sort of used by researchers and industry. And what's different with AI, with generative AI, is it's still using large data sets, in fact, maybe even larger data sets than analytical AI, but it's generating net new content that's informed by that data. So it's very good at doing things like summarizing. It's really good at generating new content. And generative AI can take multiple forms. So it can produce text, it can produce images, it can even code, and it can even do video and speech. What you're seeing on the right-hand side is actually an image that was generated with DALL-E, which is a type of generative AI. And I asked it to, I told it I was giving a lecture tonight and asked it to kind of show the group. And that was DALL-E's impression of the attendance at today's lecture. So we can see at the end if this was accurate or not. Most of you may be most familiar with ChatGPT. And so I wanted to spend a minute on ChatGPT. It is an example of a large language model. It's created by a company called OpenAI. And what large language models do is that they actually predict the next word in a series of words in a sentence, and then the next sentences that follow that. So it is just predicting the response. But some of the things that make the large language model so powerful and have the impact that it does is it is trained on a massive data set. It is trained on 45 terabytes of data. That's essentially the whole public internet of information. And the model has 175 billion parameters in it. Now, when many of you may have taken statistics, you've done regression analyses, a typical model that we're used to maybe has 15 or 20 parameters in it. Now imagine 175 billion parameters and 45 terabytes of data. So part of the reason that GPT is so different is because of these characteristics of how it was trained. In addition, after the model was trained, they used human feedback on the results to further fine-tune the model. And then finally, they have layered a chat interface on top of the model so that you can ask a question and then ChatGPT just responds to that question. And you're seeing an example of that on the right-hand side where I asked ChatGPT, what is ChatGPT? And then it responded with a definition below it. And out of the box, without any special training, the first version of ChatGPT 3.5 has had remarkable performance. It actually without, again, any additional training, it scored basically right at the passing threshold for the United States medical licensing exam. And it's performed really well as a symptom checker. And I'll give an example of that. So, right out of the box, it has some really impressive responses. The challenge is that there are some really important limitations with large language models. They will give a confident response to almost any question. Then the problem is that those responses may seem very logical, they may seem correct, but they could be absolutely incorrect and sometimes nonsensical if you know all the facts around it. They can also exhibit undesirable behavior, so they can have bias and be inappropriate. And finally, they're very sensitive to how the question is asked or the prompt. And so if you ask the question in a certain way, you might get one result. If you change that wording, you may get a very different result. So these are very real limitations, and particularly in concern when we're talking about healthcare applications. This just shows as GPT has progressed, so this is GPT-4, which is sort of the second main model that was released. And what you're seeing in this figure is performance on standardized tests. And so the blue is the performance of GPT 3.5 on an assortment of AP tests, the GRE, the LSAT, and the green is GPT-4. And you can see the version GPT-4 in some cases is scoring, 80, 90% on some of these standardized tests, again, without any specialized training. This is an example. GPT-4 has also been used for complex diagnostics. And so many of you may read the New England Journal and do the clinical pathological cases that come out every month. This is a study that basically took those cases from the New England Journal and ran them through GPT-4 and basically asked them to come up with the differential diagnosis and kind of the top diagnosis. And these are very challenging cases that are often challenging to the most astute, most talented clinicians. And GPT-4 actually agreed with the final diagnosis in 39% of cases. And in 64% of the cases, the GPT-4 model had the final diagnosis in its differential. This is very impressive, certainly better than me, and really compares to other differential diagnosis technology tools that are in the marketplace, and really shows that the promise of GPT-4 for healthcare. I really like this quote from Bill Gates. Many of you know Bill from Microsoft fame, and now certainly his philanthropy. But he basically says in his lifetime, he's seen only 2 demonstrations of technology that struck him as revolutionary. The first was the graphical user interface. This is actually a picture of Windows version 1.0. We're now on Windows version 11. And he's also saying that ChatGPT is similarly revolutionary. So I thought that was very poignant. And for all of us, I think that we're starting to see that AI is approaching human abilities and that we're using it in our everyday. So for many of you who use your phone and take a lot of pictures, you may notice that Google Photos and Apple Photos can do facial recognition. And in fact, it's powerful enough that it can track a child as they're aging and continue to recognize that child in their photos. We talked a little bit about what GPT has done with natural language creation. And then AI is also performing complex tasks. If anybody's been in San Francisco recently, they have self-driving cars just all over the city. And Waymo has driven over 20 million miles autonomously on public roads. And so AI is really starting to be kind of everywhere in our lives. And so what about in healthcare? And I always like to start, while I'm a technophile and I love talking about technology, what I'm here for, and I suspect all of you, is that we really want to have an impact in healthcare, right? We want to meet the quintuple aim of healthcare. We want to improve population health. We want to make healthcare delivery more efficient. We want to improve the experience, the quality and safety of healthcare. We want to make sure whatever we're delivering is equitably available to all patients. And ideally, we want to make sure that we're addressing healthcare workout and burnout and creating a great experience for our healthcare workers. So I think that there is a very large opportunity for AI in healthcare, spanning lots of different use cases, and that we are just scratching the surface. But I also want to point out that some use cases are lower risk than others. We often jump to, like the example I showed you with AI doing diagnosis. That is also one of the highest risk, right? If AI gets the diagnosis or tries to triage someone and gets it wrong, a patient can have a delay in diagnosis or even worse. And so those are very high risk use cases. And in fact, those likely require approval by the FDA before we do some of those use cases. On the other hand, there are other use cases that are much lower risk, like automating our contact centers. So if someone's calling for an appointment, can we use AI to help automate some of that work and speed that up? And if we get that wrong, it might be a little frustrating for the patient, but we are probably not going to cause a negative clinical outcome. And then there's a bunch of tasks that I classify in the middle, things like back office functions like coding and revenue cycle, or clinician decision support or workflow supports, where we're traditionally using AI with a clinician review. And I think these are sort of moderate risk, but do require significant validation and evaluation. And we're going to talk through some of that today. So this is to just show that there is a large and growing landscape of companies that are focused on AI in healthcare, and it spans from life sciences and clinical trials to administrative tasks like coding and prior auth, to pop health, to patient-facing tools, and then finally to clinician-facing tools. So there is a very robust venture funding environment and startup phase and industry phase really focused on applying AI to healthcare. And there are huge opportunities specifically for generative AI and large language models in healthcare. We're going to talk today a little bit about clinical documentation, but large language models could also take the medical jargon in our documentation and create a really patient-friendly version of that for our patients. It could take lab test results and translate that into patient-friendly results. It could become a behavioral and mental health chatbot for patients. So there are innumerable applications of LLMs, and you'll hear more about these later in the talk. There's obviously, with this comes a large market, and this is what's drawing the investment. And in fact, many of the analysts that are looking at new technologies are stating that healthcare use cases are expected to make up to 25% of the generative AI market in the coming years. And so I think people are recognizing that these tools have huge promise for transforming and improving healthcare delivery. I do want to emphasize that generative AI is very new. You know, I said analytical AI has been around for 30 plus years. Generative AI is 2+ years. That is early for a new technology, and particularly a new technology in healthcare. And so there are still a lot of inflated expectations around what AI is going to do. And I think it's incumbent upon us to really do robust research, evaluate and validate the true impact and value of these tools, so we can figure out which tools are valuable, which we should be using, and which aren't quite ready for prime time use yet. And so in my organization, we have divided our AI use cases. We are in early stages of piloting AI, and we have some use cases that are geared to our care teams, some that are designed for our larger employee base, some for our patients, and then some for our researchers. And today I'm going to go into a couple examples showing what we're doing using AI for our care teams, our doctors, our nurses, and others that are directly caring for patients. And I do want to emphasize this, that this is very early technology. In medicine, you know, one of our biggest sort of guiding principles is do no harm. And we also believe in evidence-based medicine. And so there is not a lot of evidence yet for many of these AI tools. And so as we look to doing pilots, we are approaching them in a very gradual fashion, when you're going to see this in these examples that I share, where we start with small pilots to assess safety. Then we do a little bit larger pilot to assess efficacy and make sure that it's quality, that it's reliable, that our clinicians like it. Then we do an even larger pilot and are checking effectiveness. And then finally, we make a decision to scale and then monitor the AI over time to make sure that it's not drifting or changing its results or causing unexpected consequences. And so now I'm going to just, in this last segment, really jump into a couple of use cases on how we're actually in early stages of using AI in our organization. And then Anna's going to share similarly her experiences at Penn. And on the provider side, one of the biggest problems facing our providers is burnout. And on the physician side, some studies estimate that over 60% of physicians are experiencing burnout. And the reasons for this are really multifactorial, right? There's pressure to see more and more patients in shorter amounts of time. It's a chaotic environment to practice in. People are trying to balance this with their own lives, their family, and their other activities. They're also having to use the electronic health record, right? They have to spend a ton of time documenting, responding to in-basket messages, and often they're doing that after hours at night. And that is all contributing to burnout. And burnout is bad, right? It reduces, it can have individual effects on those clinicians. So it can increase their depression, anxiety, even suicide risk. It also, if they are burned out, studies have shown that there are increased number of patient safety events with those clinicians. And those physicians, if they leave practice, it reduces the number of patients that have access to care. And there is a very strong correlation between EHR use and burnout. In fact, physicians that spend less than 5 hours after hours charting per week, they are 2 times as likely to report lower burnout than clinicians that spend more than 6 hours. Or said another way, if clinicians are spending more than 6 hours a week after hours doing charting or other EHR tasks, they're much more likely to be burned out. But my question is, technology is not all bad. Can we actually use technology to put the humanism back in healthcare, or put another way, return the joy to the practice of medicine? I'm going to share with you sort of 2 examples. The 2 main pain points for providers right now with the electronic health record are, the first is responding to in-basket messages, and the second is doing documentation. And I'll start with in-basket messages because overall, it's a really great thing. During COVID and after COVID, we have seen a huge surge in the number of patients that are using electronic portals and that are interacting with us using messaging. And we love it. Like, that's exactly what we want. And at MGB, we are getting over 3 million MyChart messages a month, which is our patient portal, or patient gateway for those that are patients at MGB. The challenge is that our practices and our doctors and our nurses are really set up and optimized to be seeing patients in clinic. And they don't have a ton of time to be responding to in-basket messages. And so they're often responding to these messages at the end of their day, at night, on the weekends. And so one idea is, could we use a large language model, GPT-4, to actually draft a response to these messages? And so what you're seeing on the right-hand side is a cartoon. At the bottom right in blue, you're seeing a message going in through the electronic portal to the doctor. And then the top part is showing that that message went through GPT-4, and GPT-4 drafted that response that you're seeing, where it says, "Hello, George, congrats on becoming a grandpa." And the clinician has the opportunity of saying, let me start with this draft. I can edit it, make some changes, or I don't really like this response at all. Let me start with a blank reply. So this functionality really resonated with our clinicians and our leaders. It's really addressing a key pain point, and we wanted to try it out. And as I said, in this like pilot-based approach, we want to start small to make sure that it's working, that it's valid, that it's not going to cause harm. And so we started with a small pilot of 5 primary care practices across our system. And the first day, I got like amazing feedback. People were like, wow, this thing works so well. We love it. But over time, what we found is that that initial excitement really dwindled. And over time, we actually saw that only about 10% of the draft messages were actually being used. The rest they were ignoring and starting with blank messages. And when we surveyed them, the AI-generated drafts got an average rating of like 5 out of 10. And what we learned as we dug deeper is that these messages that were being drafted didn't really capture the voice of the clinician. Also, intentionally, they weren't providing clinical advice. And that is what a lot of the messages that are going to our nurses and doctors and practices want. And we intentionally limited GPT-4 to not give clinical advice and leave that to the clinicians. And so we actually stopped the pilot. We're not expanding this right now, and we're working to see if we might retool this and use it more for the front desk staff that get more of the operational logistics questions, not the clinical guidance questions. And so this is an example where it was really important for us to do a pilot, see how it was experienced before we got everybody super excited and tried to roll this out more broadly. There are some published studies. This is a study from Stanford. They did a pilot. They had a little bit better uptake than us. They had 20% of their draft messages were utilized, but still a very modest number considering the volume. And they did, though, however, see some reduction in physician task load and work exhaustion. So I think that there's promise here, but we've got to find, we got to continue to pilot, experiment, figure out how to best use these tools to respond to the appropriate messages. All right, I'm going to switch now to documentation. I said there were two areas. The first was in basket. The second is documentation. And many of you are practitioners, after you see a patient that you have to write up a note. That note is really important for continuity of care. It's also really important for legal protection. And finally, it's important for billing, among many other use cases. And many of our clinicians spend a lot of time writing notes. And so over the years, we've given clinicians voice recognition, tools like Dragon or M-Modal, and that has definitely allowed our clinicians to get some efficiencies. We've even tried scribes, either in person or virtual, where another person is kind of accompanying that clinician, and that person is taking notes. Those are often also loved, but they can be expensive, and those scribes turn over frequently, and so it's not very scalable. And so the holy grail is this idea of ambient documentation. And what ambient documentation is it is using AI to basically securely listen to the conversation between the patient and the clinician and generate a draft note. And the way it does this is there's specialized software running on a clinician's phone. They ask for permission for the patient to record the scenario, to record the encounter securely. They record the encounter. Then that is securely uploaded to a cloud commercial application that's secure. It does voice recognition, natural language processing, and then it uses the large language models to summarize the information into a clinical note. And that draft note is then presented to the clinician for editing, review, and then final signature. And again, we were really excited about this. This is a massive pain point for our clinicians, so we were very excited. We started with a very small pilot of 18 willing, friendly clinicians who used it for a couple of weeks, and they found the system was very responsive. The turnaround time for notes was very fast, and 91% of the content was retained without any significant safety events or issues. One of their biggest pieces of feedback is, though, that it was cumbersome if it was not integrated into the electronic health record because they had to copy and paste. And you can see a quote from one of these initial participants at the bottom right. When I'm using this ambient documentation product during a visit, I've noticed that I'm able to have more face-to-face time with my patients rather than staring at my computer screen. So we were very excited by these results. Because this technology is still very new and it was unclear exactly which vendor had the best product, we made the decision to expand our pilot from those 18 to, initially we were planning to do 400 physicians and APPs across two different products, Nuance DAX Copilot and a Bridge. Nuance DAX Copilot is from Microsoft, so it's kind of the big gorilla vendor, and a Bridge is a smaller startup. As I said, we initially planned for 400 participants, and we got overwhelming interest from our clinicians, and we just couldn't say no to them. So we actually doubled the size of the pilot. I'm going to do a demo after Anna talks, but I thought I would just show a quick breakdown of these 800 pilot users. They are across all our hospital types, so our academic medical centers as well as our community centers, and across all different types of specialties. That's what you're seeing here. So we had a variety of participants. And what we found, you can see these are the qualitative results. Some of these are amazing, like the first top left, like the products are truly life-changing. And this person actually conducts 50% of their visits in Spanish, and documentation was a huge challenge, and it took a huge weight off their shoulders. These products can actually work seamlessly in other languages. So if you're using an interpreter, it recognizes the interpreter and it produces the note in English, Or if you're just natively speaking, let's say Spanish or Haitian Creole from the provider and the patient, it will also recognize that and then output an English note. I will say not everybody loves these products. So there is absolutely some people where it doesn't work with their workflow or they don't like it. And some people that are still cautious, like on the right-hand side, I'm still typing because what if there's a bug and it doesn't work? And so they're worried that like the tech might lose their content. So this is some qualitative feedback. We also have taken a much more rigorous quantitative feedback approach to try to measure the efficiency, the satisfaction, and the return on investment of these tools. And I'll just share with you, we've also done quantitative surveys to our users, and we've measured their usage. This is some data from the summer, and we're seeing that these ambient tools are being used in anywhere from 30 to 40% of the ambulatory visits. And you can see on a scale of 1 to 5, that our users find the quality, the usability, and the time savings pretty good. Not perfect, but pretty good. The difference between the green and the blue are the two different vendors. There's slight difference, but very, very similar. We have also done some analysis of the impact of these tools on documentation burden, rapport, and burnout. And you can see I mean, these are very impressive results. We have been trying lots of tools, techniques, giving away food and services and sending people to yoga retreats and have not seen impacts like this on burnout. 3 times, are no longer charting after hours, a 40% reduction in burnout, right? It's 80% more attention to patients. So these are very impressive for what they're measuring, results that we've not seen with any other interventions in this space. I will share, these are still early results. We've not finished our full pilot and analysis, so take these with a grain of salt until the full analysis comes out, but it is clearly signaling a very positive impact of these tools. And so you might be asking, well, this works great for APPs and for providers, but what about nurses who are also spending a ton of time, bedside nurses that are spending a ton of time in the electronic health record as well? And that has not gone unnoticed and is absolutely a priority both for us as a healthcare delivery system as well as for the vendors. The challenge is that many of our bedside nurses and even ambulatory nurses do a lot of structured data capture into flow sheet rows, right? You're capturing vital signs or capturing an assessment that gets coded into the EHR like you're seeing on the right-hand side. And so the ambient documentation vendors are currently working on a version of this where the nurse can have a conversation and the tool will actually translate that text and conversation into structured data that will then populate these fields. And they have early versions. A couple of institutions are testing these, and we are going to test those in the future. I'll just kind of end with, what do we need to advance all this? You're seeing a couple examples of how we're kind of going gradually, testing, validating, and that's because safety, effectiveness, reliability come first. We have to make sure that exists. We also have to make sure that there's a benefit and a return on investment. These products are expensive and we have to pay for them. So we have to measure the benefit. In some cases, it's going to require FDA approval, and Katie's going to talk a little bit more about this. We also need to make sure that there's no bias, right? That this isn't treating a certain a type of patient or someone with a certain background differently. And of course, need to make sure we're protecting the data's privacy, we're being transparent with patients and clinicians when we're using this. And as you saw, or as I mentioned, sometimes we need to get patients' permission or clinicians' permission to use these tools, like when we get their permission to record the encounters. So I think there's huge opportunity. I am going to now turn it over to Anna, who's going to share her experiences at Penn.
Okay, great segue. It's, I learned so much from Adam, so thank you. Let me see if I can move this to the side. Can everybody see my slides?
Yes, we can see them.
Okay, great. So I'm just gonna tag on and then I'll come back for my lecture series after the demonstration. But as Adam mentioned, I'm just gonna share with you the implementation we've done at Penn Medicine on ambient digital technology and in-basket response here. So we do have 2 use cases here. As Adam mentioned regarding clinician burnout or just the time regarding inefficiency. We've added the EHR at a time where we didn't know any better. And, we added like the kitchen sink into the documentation and the workflow. So now we're trying to peel back. So for problem number one, it's really the burden on documentation, whether you're a nurse or a provider. But we do know that 7.6 hours on documentation is spent weekly in pajama time with our providers at Penn Medicine. So off hours, they're in the chart finishing up their documentation for the day or for the week. We have another problem where we have a load of in-basket messages. So we have at Penn Medicine, our data shows that we have 6 million in-basket messages from patients annually. That is a lot to comprehend. And so there's a lot of hours spending time on rerouting and responding to in-basket messages. So we've tackled that. How can we solve some of this solution by decreasing some of the burden to our providers? And we at Penn Medicine have implemented ambient digital technology like at Mass General. And so just quickly is, what we've observed, and we had 2 waves and we're going on a 3rd wave, and we had 15 providers at the very beginning. When it's not integrated, we're early adopters. So it was a little rough getting started, but there was value. So we had a wave 2 and we had an integrated module. But as Adam mentioned, it is evolving, and the features is almost monthly that we get updates to our platform. But what we did learn is that it is reducing cognitive burden. It is helping it develop the patient narrative, whether you're using it right there or you're coming back later in the day. But as it's continued to develop, it's early on, and we're just looking for the other features that might be forthcoming. But one of the things I want to make sure is that when you implement, it's really important to do observation. We're in a remote world, and I do encourage people to make sure how are providers using it. I decided to do a evaluation of a provider, and we just noticed that there was other workflows that needed to be solved, not just ambient listening. So I think it's really important to do real-time observation as people are transitioning to this new technology. So here's our metrics from wave 1, wave 2, and this is before some really good features have been implemented in the last month or so. But we did notice that there was a decrease in time in the notes. There was an also appointment closure for our ambulatory practice. You cannot bill until you close that encounter. And there was a 5% increase in the closure. And then we also noticed that there was a less keystrokes. Interestingly, though, we have noticed there's an increase in our characters of our documentation. So is that note bloat or is that increased quality? Only time will tell whether or not that has increased quality. And so maybe that will help with better coding, better diagnosis. So it's just something to keep a mind on there. Next is here's just our satisfaction regarding just our provider well-being. And this is before some great features have been implemented, but in sense is that patients and providers are feeling that there's more that one-to-one interaction, and also a decrease in our cognitive burden here. So just as I mentioned that these platforms are evolving, these were the new features in our vendor that went live in the month of September. That's a pretty big, if you notice here, there's just like 8 features that gone. It's just evolving. So no matter which vendor you use, it's just going to continue to get developed, the workflow, whether it's for providers or for other disciplines. So as Adam mentioned real quickly, is that it is on the horizon for nursing. And it's really important because the burnout for providers is just equivalent in the nursing space too. And nurses are feeling burned out, 63%. They have double digits for vacancy rate. And then also people are considering changing hospitals or changing their maybe their setting or profession out of nursing. So we need to make sure that we address this burnout at all levels. But this ambient digital technology for nursing is going to be available in different spaces. So Adam mentioned acute care. We are testing it on the ambulatory side with nurses in the ambulatory space where they are doing nurse triage. There's a lot of documentation there. So we're trying that. Our home health is aching for it. It's not quite ready, but when they're ready, we'll try to do that. And then we're trying to do it also for some virtual care. But it is coming in the acute care setting. There's a lot of work and development because those flow sheets are complex. Regarding the augmented response for the in-basket, just a couple of things is initial response is that it was used 15.7% of the time. Then we kept on continuing to do better prompt engineering. And I'm just going to flip over to the next side because as we did, this is just an example of the response draft. But what we've noticed is that with our continuation of improving our prompt responses, now is that there is a reply with 35%. So it went from 15 to a little bit higher rate. And then also, just like Mass General, where is it best used? We didn't want it to do clinical advice, but we are turning it on to the nurses. We did turn it on to the medical assistants, and they were using it maybe 100%. And we thought, you know what, it probably shouldn't be as high. So our strategy now is to turn it on to the front line, to the nurses and providers, but we are going to scale it back from our medical assistants. But we are proposing at the next steering committee to go enterprise, right? Because I think we're at a point where it can be useful, and that's what our data has shown is showing us. Here is where you can see also from a plot regarding responses regarding who was using it. The green is the registered nurse, and then the red is the physician. But you can see regarding the medical, the blue is the green and the blue are licensed nurses, but the medical assistants, if you can see here, they have some high rates here. And that's one of the reasons is even though it may look good, you may have to dig deeper because they were using all the responses, sometimes whether it was appropriate or not. Okay. And then, but it does look to be potential promising, but again, you have to make sure that you have a support model and understand who it's for. So that's, I'm going to stop sharing. We're going to do a quick demo and then I'll come back and do my lecture. Okay, Adam.
Thanks so much, Anna. And hopefully, I know I just learned a bunch and clearly want to learn about their in-basket experience. I think what this also shows, it shows how early this is and why both of us, Penn and NGB, are spending so much time piloting, slowly scaling, evaluating, because we're learning how this technology works and where it works best and making sure it's safe. But now we thought we'd actually show you a demo of this in action. So I'm sharing my screen, but for the first part, there won't be a lot on the screen. And Penny has kindly willing to be a patient. So we're going to do a couple minute, maybe no more than 5 back and forth kind of simulated patient encounter. I'm going to, it's going to be recording on my phone, and then I will stop recording, and then you should see something on the screen. I will say we didn't rehearse this, and for those active clinicians in the audience, if I do some crazy clinical maneuver or recommend something foolish, please know this wasn't planned, and I'm also trying to be brief. But first I'll ask, so thanks for coming in today. I'm using a tool to help me be more efficient with documentation. Would it be okay if I record the encounter with you?
Sure, I think so.
Okay, great. So I'm just hitting start on my phone. Great.
As long as the encounter, does it get the, you know, like destroyed, the recording eventually?
Yep, it will be, the recording will be destroyed.
Okay.
Great. Well, thanks for letting me use it, and thanks for coming in today. What brings you into the office?
I got bitten by a cat yesterday.
Wow, where did the cat bite you?
in my hand. And
On your
it's like right, like on both sides of my thumb. It's even on the palm of my hand.
Okay. How many, can you see how many times the cat bit you?
The cat bit me so hard just once that it was hanging on to my hand.
Oh my gosh, I'm so
I
sorry.
had to break it away.
Okay, so that, and this was your right hand?
Yes, it was my right hand.
Okay. And this happened yesterday.
Yeah.
And then what did you do kind of after the injury?
Well, I did go to urgent care and they gave me a medication, an antibiotic, and I'm taking that, but the hand is getting more and more swollen and painful.
Okay, well, I'm glad that you came back here today to get it checked out. And by the way, did you know whose cat this was? Was it your cat?
Yes, yes.
Okay. And it's yours, your cat?
No, it's not my cat. It's a friend's cat.
And did that cat have all its vaccines and had gotten veterinary care or?
Oh, I would assume so, but I don't know for sure.
Okay, great. Um, okay, so and you took the antibiotics from the urgent care? You got the prescription filled and took them?
Yes, I did. And well, now it's been, let me think. I've been on it for like, 24 hours. I've taken 3 tablets.
Okay, great. And I'm sorry to hear that the swelling is continuing. Are you having any fevers?
I have a mild fever. It's like about 100.
Okay, great. Any nausea or vomiting?
No.
And have you taken any pain medication?
I take Tylenol for the pain. I don't have anything else I can take, but it really hurts.
Okay. When was the last time you took Tylenol?
I took it about 6 hours ago.
Okay. And do you have any other medical problems?
Oh, I do. But I think, yeah, the two major ones that I do have is I have rheumatoid arthritis and I have diabetes.
Got it. And for your diabetes, what type of medication are you taking for that?
Oh, I take insulin.
Okay. And have you checked your blood sugars recently? How are they doing?
No, I didn't. The
Okay.
hand has been hurting so much.
Okay. No problem. Totally understand, and we can check that here today. Do you know when your last tetanus shot was?
Yes, that I do know. It was like 5 years ago.
Okay, great. Any allergies to medications?
I have none.
Okay. Um, all right. Thank you for that. I'm going to do a quick exam. First, I'm just going to check your vital signs. I'm seeing here that yes, you do have a fever here in the clinic with a temperature of 101. Your heart rate's 105. Your respirations are 20. Your blood pressure is 110/70, and your oxygenation, your pulse ox is 98%. So your numbers look good, but you do have a little bit of a fever. And then on exam, I'm examining your right hand, and I can see the puncture marks to your point right by the right thumb at the base of the IP joint. And I am seeing a considerable amount of swelling, some erythema, warmth to touch. But you do have good range of motions in your joints, and I'm not appreciating any fluctuance or signs of deeper infection. And your pulses are normal and your range of motion at your wrist is normal. So thank you for letting me examine you. So you were very smart to come in today, and you did all the right stuff by going to urgent care and taking the antibiotics. But I am concerned that that you're, despite doing all that right stuff, you may have a cellulitis or an infection from that bite. And so what I want to do today is we'll do a quick blood sugar test. We'll also check some laboratories. So we'll check a chemistry panel, a CBC, We'll also put an IV in and give you a dose of vancomycin antibiotics to get you started. I will also check an X-ray just to make sure there's no foreign bodies. The cat didn't, there's nothing else in there. And then we will have our hand surgeons come see you as well. We want to watch this very, very carefully and make sure that the swelling, the redness, the fevers are getting better with the antibiotics. So I am going to admit you to the hospital for a very close observation and continued IV antibiotics. Do you have any questions for me?
No, but I have to say that this particular history, if I step out of my patient role, happened to a good friend of mine within the past 48 hours, and they did just as you did, admitted her to the hospital.
Okay, good. I'm sorry to hear about your friend, but I'm glad that they got admitted. And so just to pause on that, I just stopped the recording. And now, actually, you can see on the screen where it says Regis lecture recording on another device. Can you see that on the top left-hand side on the screen? Hopefully folks are able to see my screen.
Yes, I got it on mine.
Great. I am now going to stop the recording and hit create note. And what you're going to see is it's uploading, when I described it's uploading that recording to the cloud. Now it's actually doing the speech recognition, natural language processing, and large language model summarization. And within a couple seconds here, you will see the note pop in. And we will see how well this ambient documentation did. And of course, whenever we're doing a demo, I always get stressed, but we'll give it a second here. There we go. All right. Here's the note. And first, you may or may not remember, we started with Penny was asking some good questions about does the recording get saved or not. Notice how that's not in the note, and it starts right away with patient presents with a cat bite to the right hand around the thumb, occurred yesterday. Cat was hanging onto the hand and had to forcibly remove it. The patient went to an urgent care facility where they were prescribed antibiotics despite taking 3 doses. The patient reports increased swelling and pain, fever of about 100, took some Tylenol. So you can see the history is very good. Here's the physical exam with the vitals that I verbalized, and then some puncture, describes the physical exam. Again, I had to verbalize. You have to do a good job verbalizing. I didn't do the best of all jobs. And then it has an assessment and plan. Cat bite wound, increasingly swollen and painful, considerable swelling, erythema. Patient has a mild fever. We're going to admit them to the hospital for observation of IV antibiotics. We're going to check blood sugar, chemistry panel, and CBC, give IV Vanco, and consult the hand surgeon. So you can see it got everything right. It even did problem-based charting and added rheumatoid arthritis, which there was nothing acute going on. For diabetes, though, yes, it actually captured, check the blood sugar, continue the current insulin. So it did add some content there. I'll also show you that what's also powerful on the right-hand side, you can see the text transcript. So if I had a question of like, what did I say? Or which, where did the cat bite you? I could see, I can go through the conversation. I can also, in the history, say where really the patient said they had a history of rheumatoid arthritis. If I highlight that, on the right-hand side, you can see it's saying linked evidence. It's going to the transcript and showing where the patient and I had a conversation about rheumatoid arthritis. So anyway, this is hopefully gives you a sense of like, this was not rehearsed. This was a real case. And you can see that ambient documentation, I think you guys can be the judge, but I think did pretty well at this. So I'm going to stop. I know I've probably taken too much time here. I'm going to stop and turn it back to Anna, and then I hope we'll have time at the end for questions and discussion around this. But I know Anna's got a lot more material to cover.
I just have to say that was amazing.
It is pretty cool, isn't it? It is really taking a burden off of our providers, and it's going to be amazing what else is coming, because in the conversation, if Adam has suggested you to go to get blood labs drawn, eventually it will say, well, where do you live and what lab center do you want to go to? So it should prompt that eventually. If Adam was asking regarding a certain diagnosis, it may say, you know what, you can change maybe the diagnosis to something a little bit more complex, but it's going to be adding on beyond the scribe component. So we'll see what happens in the months to come. So I'm just going to switch gears a little bit and talking a little bit more about the bright side regarding AI. And I have the fun piece of the lecture series here today. So I'm really excited here. I'll talk about just a diagnostic, treatment, and drug discovery where AI plays a role. And I'll skip from what I already presented. But regarding just where is AI going to make a dent in what we do in healthcare. These are just some of the possibilities where AI is making a difference. And but we'll focus on just a few of these today. We could spend hours here, but I'll do maybe the first 5 little tiles there for this lecture. We'll talk about diagnostics, treatment, patient care, clinician experience we talked about already, personalized precision healthcare, and then some advances in surgical capabilities. And I'll just do highlights. But before we begin, especially for nurses, you want to be at the table to have that conversation. But as nurse leaders, I'm going to point to this slide because I think it's really great, but I co-chair the HIMSS Nursing Innovation Advisory Work Group and worked with a couple colleagues who did this publication, but it's the 5 rights of AI. And you just want to make sure you are going to solve a problem and you have objectives outlined of what you're trying to improve and capture the data, and just to make sure that solutions are costly, is resource intensive. But as long as you know what objective problem you're solving, that's the first point. You want to make sure it's the right approach. Yesterday, I sat in an award ceremony regarding quality and safety. It wasn't all about solution. It was also about workflow changes or education. So it's just what is the right approach. But as you do implement AI, it's just what is the competency that you as a leader, you as a nurse or a colleague needs to understand regarding the competency of AI. And really, Adam did a really nice job of providing a lot of knowledge base this morning regarding the different aspects of AI. And then really, this is where nursing comes in, is regarding the right data. You got to just push if you work for a large health system, it's just what's the data definition, but how are you collecting the data and how many times are you collecting? It should be one master record that you're collecting the right data, but not to have many iteration or variation. It should be that right data so that it can feed data analytics, it can feed AI solutions, and then to make sure that you have the right safeguards. Adam touched on it briefly at the very end, is to make sure it's not it's safe, it's accurate, it's inclusive, there's no bias. You got to test and make sure those systems are done, not just at implementation or evaluation, but it's on an ongoing basis as you have upgrades or you have additional data that's being entered into the system that may recalculate your algorithm. So regarding one area that is really making a splash in AI is in the clinical imaging space and the diagnostic world. They're just a little bit further ahead. It's maybe more black and white regarding the nodules that may be indicated in the imaging, and you need to look a little closer. But there is a lot more development in the clinical imaging space. And so I'll share with you a few things that we're doing at Penn Medicine. But with these diagnostic and treatment with AI, we're able to do quicker diagnosis and then quicker treatment and to personalize those treatments for our patients. So here, these are things, I did take the vendor name out of the solution, but here we have the different areas that we have in production regarding where AI is making a difference. So we have it in the breast imaging, we have it regarding body fat, we have it where it's stroke detection. And so it says whether or not, you know, somebody is suspected of what type of stroke or how intense that is. We have AI for thyroid as well as lung modules here too. And then now we're even, I've just left a meeting this afternoon, if somebody has a positive result, is how are you following up? So it's just taking it through the close the loop workflow as well. So that was my meeting. One of my last meeting of the day was if somebody has a positive lung module, what is the workflow to continue to make sure that the patient gets seen? So it's not just about it all once and done, it's just to make sure that the patient gets seen at the provider and has some follow-up. Here are areas where we're doing implementation. We're right now in the implementation. So it's not just one, but we have several on a docket, from pulmonary embolism detection, general impression, neurology. And with all these different AIs, we have now said, you know, is there something regarding an orchestrator, something that can help with the implementation of all these tools? So we are starting to look at kind of a middleware, if you will, of an orchestrator to help with some of these deployments of AI. And that's what we're using regarding something for data streaming, cancer detection, fracture detection, and some things for analytics there. So just wanted to share how busy it is in the clinical imaging space. Then also in regarding patient care and outcomes, one of the things that's been great is, especially with the pandemic and patients being wanting to be seen at the home, there's been a lot of increase in home care, but also a hospital at the home where we're doing more real-time monitoring of patients. So that is where AI is playing a role in maybe being monitored by a central staff at one organization or even across the country. And then predictive analytics is another area. It's just using predictive models to detect maybe a condition or preventing some other complications. So here, real-time monitoring of patients. People are wearing sensors or wearables in the home or walking around and help send messages to caregivers. We're able to also track vital signs of patients wherever they may be. That can be early interventions, whether it's in the hospital or outside the hospital before complications become serious. And then I think many of us have seen publications regarding early detection, such as sepsis, that we're looking at. And if there's any early warning signs, then that also notifies the care team. Some other areas regarding predictive models, and these are some that we are entertaining or we have implemented at Penn Medicine, is that there's predictive models, whether they're vendors or they're custom, is to look at, you know, can we look at detection of patients that may be at risk for ED admission. So that may prompt a message to a caregiver or a case manager that's following that patient. So somebody follows up. We are looking at risk for falls, and maybe that we use a screening tool of some sort, but then it is a predictive model of the ongoing assessment and check. So we're kind of doing a blend of a screening tool plus a predictive model. And then maybe of an area where a patient may be qualified for palliative care and want to engage the right discussion with the right caregivers for palliative care. Sepsis is an area a lot of people are looking at, early warning signs, whether you use the vendor model or your own custom, and then risk of unplanned admission as another one as well. So those are just a few things from a predictive model standpoint, but no matter what, these models need to have a sustainment support team to make sure that they are continued to be validated on an ongoing basis. It's not a one-time done deal. So I'm going to skip over this because I covered that with Adam, which was great. And then I am going into the drug category, accelerating drug discovery and development. This is where AI is also making a big splash. It's regarding how can AI help in drug discovery and targeting, whether it's new drugs or improving drugs already on the market, but looking at different patterns and different relationships so you can get them to the market in a quicker fashion and look at efficacy and toxicity. I think this is where pharma is involved, but or at your own academic health system is there. And then also clinical trials. So with certain vendors, there are big databases that you can use. I think Penn Medicine is a part of the database regarding an EHR is unidentified, but if you wanted to do research of patients with certain kind of hypertension, you can get access these databases, and then you can also ask to see if patients want to participate in clinical trials. They don't have to necessarily now be at your local site. It can be national, and you can have more people participating. Also, I should say, even with some of these databases, you can ask, is somebody that has similar drug type or drug diseases, that you can also see how another provider did that treatment. So really, AI is going to make a difference of enlarging our database, not to just your health system, but also across the country here. Okay. Just further on regarding just how AI is targeting certain types of drugs, but it's really just speeding it up more quickly and more accurately. But again, always tread cautiously with AI tools. And then I did talk about this just a little bit regarding just genomics, and but as we get more detailed of the patient makeup, whether it's biomarkers or just more of a complete record of the patient, and it doesn't have to be only at your site. It can be if they were seen at other institutions. We will be able to bring that data in to be able to offer up tailored treatments for the patient, as long as the patient allows you to gather that information. So again, maybe Catherine will talk about regarding just, opting in and opting out of just sharing of information. But again, if you allow the data to be shared and you get from other providers that you've seen, that the provider that you're seeing for a specialty or a certain disease will have the full picture, and then AI might be able to tailor that treatment even more. And just with a lot more development in genomics, as well as with different vendors coming in, labs, is that we'll be able to deliver really precision medicine to our patients. So it's more tailored with their makeup, and then how they want to also is to make sure from social drivers are part of that, what their wishes are, and also if they need financial assistance, they probably can bring in, what grants might be available for certain drugs or costs, so it can help tailor the treatment. The last area that I want to speak is just the advances in robots or just surgical capabilities. This is going pretty fast as well, with a lot of engineers dedicated in improving the surgical robot space. And just regarding just from eyeglass wear to getting in and seeing the view, but also understanding the data as physicians or surgeons do the surgery, and then also the quick specimen result time, and then providing a different, from a tissue analysis or blood analysis, is really be able to treat our patients faster, but also regarding precision medicine here. So regarding AI, as I got to have the brighter side of AI and the benefits, it is that we can do faster diagnosis, we can accelerate the treatment, we can personalize care, and then have better patient outcome and experience. And all this, we do want to reduce redundancy Also, we want to rationalize our solutions. So we want to have cost reduction. And at the end of the day, all we want is to improve our productivity and our efficiency and just reduce our cognitive burden. And in the end is to make sure that our clinicians have an improved clinical experience. And hopefully with all this, it's really simplifying care delivery for better patient outcomes. So here are the potentials, but as we look at AI, it does have an impact on healthcare, but we got to do it for the right reason, understand the 5 rights, and then also to balance the investment regarding safety, start with a pilot, and make sure it validates your objective and validates the accuracy as you're putting in there. But I'll just end with whatever you do need to involve the clinician. They need to be part of the loop. There are some states that have it part of their regulatory regarding AI. I think there's several states that clinicians have to be in the loop of the decision making. And so it's to make sure that there are humans in the loop of being at the table, selecting the right solution, validating, implementing, but then also to have a sustainment model. Thank you so much. And I'm going to turn this over to Catherine now.
All right, wonderful. Penny, if you're there, can you just remind me, I think we might be running slightly behind, what time you wanted to start the discussion and Q&A so I can maybe accelerate through some of my slides if needed.
I think you're going to be quite fine. If we start the Q&A at 10 after 8, that's fine.
Okay, I should be shorter than that.
I
Okay,
know,
wonderful.
I know, you've rehearsed.
I never want to run over. Okay, wonderful. So let me share my screen. And okay, give me one moment here. Okay. All right, so hopefully this should work out. Okay, so wonderful. So to reiterate again, my name's Katie Goodman. I'm an assistant professor at the University of Maryland School of Medicine, and I am not a clinician. I'm an epidemiologist, and before that, actually practiced FDA law before shifting gears. So I bring a slightly different perspective possibly to this talk. And I was tasked by Penny to talk about AI in healthcare, the shadows. I have nothing to disclose. And so I was kind of happy when I was given, the task of the shadows. And I think oftentimes, especially when we're talking about law and regulation, it can be a little bit negative sometimes. Lawyers are always the one that kill the fun and the innovation, or they have that reputation. And I think I want to emphasize that, the challenges around AI, we should view them as challenges, not something to be fearful of, but an opportunity to do better. And so actually, this is my favorite painting ever. It's a painting by Edward Hopper. And I love it because we can see here that, the shadows, it's just an opportunity to bring an issue into the light. Once we can shine some light on it, be aware of it, then hopefully we can solve it. And so that's going to be the focus of this talk with AI. Okay, so in my roughly 20 minutes or so, I will give a very quick 1-slide refresh of Adam's earlier talk on the distinction between analytic and generative AI, because it becomes relevant to the regulation of these tools. And then I will talk about some of the challenges around accuracy, equity, and regulation in AI, starting with analytic AI, where we've seen a lot more progress. It's older, it's been around longer, and then focusing specifically on, new and incoming challenges unfolding with generative AI. I'll talk a little bit about places where I really see generative AI going. So we'll give 2 specific examples. And then finally, I'll finish with, what do I really want the nursing profession, clinicians, regulators, and of course, patients. At the end of the day, we are all patients as well, to be thinking about and anticipating. Okay, so just to refresh from Adam's very helpful overview at the beginning, when we talk about AI, that's really a broad umbrella. And so at the top here, we have the older, more traditional predictive, sometimes in MyFit we call it predictive AI, or as Adam called it, analytic AI. But at base, the important takeaway for you is that we have some type of classifier or algorithm or model that is taking certain inputs on the left, such as patient characteristics, labs, vitals, etc., synthesizing them, fitting parameters to then predict some type of output, whether it is a probability of disease, a classification, a risk score, etc. In contrast, generative AI, and specifically the large language models, they are taking inputs that are free text, they look human-like, and they are generating new content that also looks human-like, and you can interact and query with them in a human-like conversational way. Okay, so focusing first on predictive and analytic AI, we'll talk about some of the challenges with these tools, and then importantly, some encouraging recent advances. So I think first and foremost, when we think about predictive AI, and here you'll probably hear me mostly talk in the language of clinical algorithms, but by that I mean machine learning or actual predictive, more complex predictive AI, but something that is making a prediction about a patient. And I think the most high profile and concerning examples around these tools has been just some of them do not perform very well. They're actually just not that accurate. And probably the most high profile case has been, and this was, really came to light in particular a couple of years ago in sort of spring, summer of 2021. Epic had an AI sepsis algorithm that was disseminated through individuals that had Epic EHRs that basically had a lofty and important goal of predicting patients who are at risk of progressing to sepsis or septic shock. The idea that if you could identify them early, you could intervene and prevent the worst outcomes. Well, the problem, and we saw this is a study from JAMA Internal Medicine published just before the Stat News article that I showed on the previous slide, is that actually this algorithm just didn't perform very well. And so ultimately, it was missing about 2/3 of the patients who actually did have sepsis. And it was also flagging or alerting, on a lot of patients that were effectively false positives. So like almost 9 in 10 of the patients that it would flag as that did not ultimately have sepsis or progress to sepsis. And so in the parlance of if you build these types of prediction models or algorithms, we would say that it had, suboptimal both sensitivity and specificity. So just somewhat inaccurate across the board. There was also another study more recently that actually took this model and applied it at 9 different hospitals across the US with differing characteristics. And if we're looking at the y-axis here, that C statistic, it's also called the area under the curve. It's a measure of a model's discrimination, which we can think roughly as accuracy in this context. It's not quite that, but that suits for these purposes. And what you can basically see is that the performance of this model varied substantially across different hospitals, and in particular, based on the underlying incidence or prevalence of the outcome it was predicting, which was sepsis. And this is a known challenge of prediction models, and there's not necessarily an easy solution for it. But what it means, and that's concerning, is that before this, I think there was this idea that you just push out a model, you can use it everywhere. There's appeal that, there's one model from Epic, and an institution locally doesn't then need to do anything with it. And, it's really become clear over the last decade, and in particular the last few years, that is not the case, that you need to be testing these models ahead, tuning them and validating them in your local population. And that really was not the done thing before. And so why wasn't it the done thing before, and what did this culminate in? So the reason that Epics and others and researchers, I count myself among them, we've developed algorithms over the years that we hoped to implement into clinical care. We weren't ultimately successful, but that was the goal. Why on earth could it be that unlike drugs or other types of medical devices, you could just build something for clinical care and use it and never have to prove it went through testing? And that's because historically, these types of clinical decision support tools, as they're called, were not regulated by FDA. In late September 2022, FDA issued what's called final guidance for clinical decision support software. FDA rarely issues new regulations. They often go through a route of this guidance documents, but it effectively has the force of regulations. Like, you do not want to fail to comply with FDA's final guidance recommendations. And what they said in this was that they are interpreting that actually many clinical decision support tools actually do qualify as medical devices, and you could risk being in non-compliance and using a non-cleared device if you weren't taking certain steps to validate and test the performance of these tools before deploying them clinically. And they specifically called out that they would target, to begin with, models that are used for life-threatening and time-critical conditions like sepsis. And we wrote a piece on this right after it came out in JAMA. I think this was ultimately a good and important step. I do worry it's a little bit broad, and we talk about that in that piece if you're interested, but it's a net positive step. Okay, so the sepsis model example, that was an example where it's just not very accurate across the board. And in some ways, you know, while methodologically that is bad, it can be a little bit of a safety valve clinically, because providers didn't like the algorithm. They thought it was annoying. It would put up a lot of false positive alerts. And so they didn't actually rely on it very much. The problem you can then run into, though, is where an algorithm is accurate in some groups, but not others. And we call that, it has differential performance. And in that case, the algorithm is biased. It will actually perform worse in one group of patients compared to another. And that might be undetected. And that's even more dangerous, right? Because providers or clinicians may think, oh yeah, this is a good algorithm, not realizing that for a certain subset of patients, it isn't. And so where we have seen this in particular, and this ties into equity issues, of course, is algorithms that perform differentially worse in minority patients, in particular Black patients in the US. And so probably the most high profile example of this was an article by Ziad Obermeyer in Science in 2019. And what they examined was a large commercial algorithm that was actually less used by hospitals and more by insurers and other managed care providers to identify high-risk patients for targeted interventions. For example, community interventions, follow-up with text messages, you know, better management of chronic care conditions. And so all of this relied on being able to target those highest risk patients. And the trap that they fell into was that when they built this model, because they didn't have granular data on all of the different health conditions that patients had, and this is a common pitfall, when you don't have an electronic health record database, you often don't have those data that you want. So they used prior healthcare expenditures as a proxy or a surrogate for the complexity of your health needs. And it turns out that is not a good surrogate. It's actually biased, because it meant that because historically minority patients, even when they're sick, use less healthcare and don't have the same access to care, it meant that using cost as a proxy made them look less sick and in need of care than they actually did. And so the net result was that you could have an equally sick Black patient and an equally sick white patient, and the model would predict that the Black patient was low risk and that the white patient was high risk and should be targeted for further intervention. And so I really want to credit, though, the researchers that did this analysis, and also the company. They never named the algorithm, but they actually reached out to the algorithm company. And, you know, that company did change this algorithm. And I think, you know, I really like that Ziad Obermeyer in this article, you know, he emphasized this shouldn't be a story just about good and evil or algorithms being bad or algorithmic bias being bad. It's that we need to be aware of these challenges and taking methodological steps to help mitigate them. And of course, the standard of care, humans are biased too, and algorithms will just model the reality of the training data that they're built from. And so it's not to say algorithms are bad, it's to say that there are challenges with them that we need to address. And then finally, I'll take less time on this, but just to be aware, I'd say another very high profile example where we've had algorithmic bias conversations and equity. This was an article in the New England Journal of Medicine from 2020, and it was highlighting a different issue of when algorithms. So the prior example was where, you know, race was not actually in the model. It was not a predictor, but there was a flawed proxy on the outcome of using healthcare costs and expenditures as a proxy for underlying severity of illness. Other examples are where race is actually in the model and we're changing our predictions based on a patient's race. And what, you know, this article highlighted was that we actually need to take a deeper question of, is that ethically appropriate? Is that equitable to change our predictions of a patient's risk or where we should target interventions based on race? And then you have to dive, you know, behind the scenes basically of why do we think race is associated with this outcomes? Is it fair to change predictions based on patient race? And so there's been a lot of governmental activity and progress in this area in the last few years. Department of Health and Human Services and AHRQ have had large working groups investigating the issue of algorithmic bias as pertains to race. And in fact, very recently, HHS just issued a final regulation, which will take effect in May of 2025, that actually says for a wide swath of patient care decision support tools, including clinical algorithms, that if they include a legally protected trait, and so those are things like race and sex, but you know, in particular in their examples, they focused on race. If that's in the model, then providers using this must exercise reasonable efforts to mitigate the risk of discrimination. And this is important because this liability attaches not to the developers, but to the providers, the end users, the healthcare systems. No one knows what this means in practice. Hopefully we will get some more clarity before next spring, but just be aware that this is a landscape that's radically changing. And then finally, this was a piece that we had in New England Journal last year, if of interest. It's just basically explaining that, you know, we've taken all these steps to improve the safety of clinical algorithms and predictive AI, and the government has taken a more aggressive stance in making us proactively demonstrate that they're safe and effective before deploying them clinically. But a good clinical reliance on an algorithm requires not just a good algorithm, but teaching clinicians how to use them appropriately. And that's something that, at least in medical schools, we feel like is a real missing piece of this puzzle. So this was a piece that was focused on that. Okay, so shifting now to generative AI and specifically some challenges. Okay, so clinical generative AI, it's a bit of a wild west. And I've highlighted here, so as I mentioned in the previous slide, this clinical decision support software guidance, if you'll notice, FDA released that on September 28th, 2022. When was ChatGPT released publicly? Oh, you know, just about 2 months later. So poor FDA, I don't envy their position, but effectively, they had a multi-year guidance document that was finalized and didn't really contemplate clinical uses of generative AI. And I say this because don't worry about the details here, but this is a graph that outlines all the lengthy document of what will make something that's a clinical decision support tool qualify as a regulated medical device or not. And I just want to call your attention to the yellow box here, where in particular, FDA has phrased things that if it's giving a risk score for a disease or condition, or a probability of disease or condition, and arguably like some type of diagnosis, you know, it will probably be a device. But things like summarizing information, all the examples that were talked about earlier in the talk by Adam and Anna, that's in a real gray zone. And under the four corners of this document, you know, they would not qualify as devices here. And in fact, I think we see further real world evidence of that by the fact that a lot of these tools that we've just discussed in the last hour were piloted and deployed in clinical care, you know, without FDA weighing in or getting involved. And so, you know, what might some of the concerns around this be? So we rewrote this piece in JAMA almost a year ago, and this was early days, but we were trying to highlight basically that you have these LLM devices, or not devices, I won't say devices, you have these LLM-based tools, in particular ones that might be focused on summarization of information in the chart, which would not currently qualify as medical devices, and yet, you know, I call it sort of like they're coming in under the cloak of reducing administrative burden, that they sound like they're an administration tool or a documentation tool, but in fact, they could have much larger clinical implications. And by this, I don't mean the type of AI scribes or ambient dictation technology that we've talked earlier about. I mean more summarization of actual medical information from the patient's chart. And so we can imagine, you know, if you have a patient in the ED, and you want to quickly find out, you know, were they seen in this institution or health system in the last couple of years? What did they have with it? That can be information that's timely to find. I think we can envision that LLMs might one day be helping to summarize this information for clinicians. And one of the things that we highlighted in this was this term called sycophancy, where, you know, an LLM, as Adam mentioned, can be very sensitive to changing the output based on how the prompt is phrased. And, you know, what we found here was that for exactly the same history, we fed them de-identified past discharge summaries and a bunch of lengthy text. Depending on whether you said that you were worried that, you know, they might be having an MI versus pneumonia from their shortness of breath, the summary of their past medical information actually changed, and it, you know, upsurfaced, as they call it, the cardiovascular comorbidities and versus those that might suggest infection. And in neither case was it wrong. They were both accurate. But you can imagine that this can sort of reinforce, potentially, if not deployed sensibly, a type of anchoring bias where it's just giving a feedback loop of what the physician or clinician was already suspecting. And that doesn't mean it's a bad tool. It probably could be very useful, but we need to be aware of those challenges and proactively attempting to mitigate them. Okay, finally then, I think particularly with generative AI, I certainly have some structural equity considerations. So in contrast to individual level patient equity concerns, in particular, I'm worried about equity across facilities with different resources. So the type of ambient dictation technologies that we were talking about tonight, while they aren't necessarily designed for this purpose, I have a strong suspicion that eventually they will be designed, or maybe already are, to optimize for billing and revenue, that making sure those summaries are documenting the conditions that will support the highest reimbursable codes. And you can imagine if there's health systems that are using these technologies versus not, that we may further exacerbate the haves and the have-not facilities exactly in terms of how they're actually being reimbursed. And these are challenges that are not new. Already facilities use natural language processing tools by 3M and others to actually help with coding and billing, but it's just puts this challenge on steroids. Also, some of these tools, in particular, the more predictive AI even, they really do require on-site expertise in order to validate these models and tune them for the populations. And how that's actually going to be feasible for lower resourced and non-academic institutions is something that we're still trying to sort out. But if we think that these tools are actually beneficial to patients ultimately, you know, whether you show up at a hospital that does have them and those resources versus does not, at one point down the road, you know, could actually have influenced the quality of care that the patient receives. Okay, so my last couple of minutes, and Penny, I apologize, I probably have gone a little longer than I planned, but we'll definitely be before 8:10. I just want to talk about two concrete places of where
You do
generative
not
AI.
have to go so fast.
Okay.
It's okay.
Okay, where it may be going. And I'm going to give an example here of a clinician example and a patient-facing example. So the first one, as I sort of mentioned earlier, and as Adam also mentioned, you know, the EHR is not widely loved by clinicians. It makes it very hard to find information. It contributes to burnout. And in fact, this was a study by Ted Melnick and colleagues at Yale, and they had users rank the usability of different technologies. And we can see that, like, not unsurprisingly, the EHR gets a score of an F relative to other technologies that we use in daily life outside of healthcare. It's really reviled almost universally. And this can contribute to diagnostic errors because clinicians don't have the information that they need in a timely manner to guide care decisions. And so I absolutely think, as I alluded to, and it sounds like, Adam, you may already be piloting at MGH an Epic tool on summarization, but that we will see more and more foray of LLMs into summarizing all the copious and huge volume of information about patients that lives buried in the EHR to put it at the clinician's fingertips at the time of clinical decision making. And in particular, and this is where a lot of my work is also focused, you know, we have a lot of information that is living in the EHR, really over 80% of it in what's called unstructured data, which is free text, flow sheet information, H&P notes, etc. And historically, absent human review, we haven't had a good way to get the information in there out to models and to make it usable by machines. And so I have ongoing work that's actually focused on just extracting information such as recent long-term care facility exposure from the notes, because it's a really strong predictor of whether you're likely to be carrying drug-resistant bacteria when you enter the hospital and can inform targeted screening decisions. But I just want to highlight here, and this is work we're about to submit, but one of the ways that we've been evaluating these LLMs is not just to extract this information, yes, no, from a note, but also to give its rationale. And it's kind of wild, some of the rationales that we are getting out. So like this was an example where, the LLM predicted a patient, not on this note, but just another one from our health system, was not long-term care facility exposed. And it actually used, I'm not going to say it was reasoning, but it evidenced a type of like inferential logic of basically saying, because the patient had been found alone at a restaurant, that's arguably incompatible with that it's living independently and not in a care facility, and just the types of things that a little bit blow my mind. And I do think we potentially will see more of them in this almost co-pilot role of where the physician may be able, or clinician, to query the LLM as it brings information in. Okay, well, what about this? What about these lab values, etc.? So then I guess the question there is, I do think this will be a very powerful tool, but I do worry a little bit that, is using LLMs, as I call it, to fix the sins of the EHR and its poor design and usability, a good use of computational and environmental resources. So these models use an incredible amount of energy. Washington Post estimates that just for a 100-word email or so, they each use a bottle of water. These firms are contemplating purchasing and building nuclear plant power facilities across the US to power these models. So I think as a society and as a healthcare profession, we need to be actually asking, and soon, where do we think there is value and it's appropriate to use them versus tasks that actually might be able to be solved in another way. Then the second example, which is patient-facing, as many of you may be aware, the 2016 Cures Act, it had a provision that went in effect in 2021 that basically makes all patient care information, as soon as it's available, unless you opt out of this, it gets pushed to a patient portal. And like, for example, if it's Epic, it's MyChart. And these become available to patients in real time. And on the one sense, it's great to push more information, transparency, and power for patients to have over their data. But at the same time, I mean, it makes me, infuriates me in some ways, because like the number of friends, for example, I have that have gotten radiology reports before they have follow up with their specialist, they don't know what it means, and you're left with this information and you aren't really guided in what does it mean. And so, for example, I don't know if anyone is a fan of The Office. I love Jenna Fisher. She was on Today's Show last week or earlier this week talking about her recent breast cancer diagnosis. And she was saying that basically she had had a biopsy. They told her it was low risk of cancer, probably. She was on a hike and her results popped up in her portal. And she sees words like invasive ductal carcinoma malignant. She's like, those sound like cancer words. Well, she's getting that information before anyone can interpret it for her. And so we have actually seen start for targeting to patients, and not just by health systems, launching tools that will translate these reports into something that is accessible to laypersons and non-medical audience. And I think the question here that we want to be asking is, just because we can do that, do we really want to be? Do we want AI to be filling this gap for patients? Is this a sensible way to use this technology? And in particular as well, there's some liability issues here of, once you have patients feeding these to LLMs, there's questions around who owns those data. And I think we could almost envision at some point potentially apps marketing to patients of saying, get a second opinion for non-medical purposes only. They'll sort of couch it in legal disclaimers, upload your imaging and the reports, and it may even flag potential areas. So I just think this will be an interesting space to keep an eye on. And so then in my last slide, I've listed here, I have a long commute. So I live in Alexandria, Virginia, but I work up in Baltimore. So I'm in the car a lot, and I'm always thinking about these issues. And so these are sort of three open-ended questions that I leave you with. And I think the first is really, what are the aspects of healthcare and medicine that we actually think should be reserved for humans? And increasingly, this is a value question in some ways more than a technological question. And I think now is the time that it's incumbent upon us to start really thinking about where do we think these boundaries should lie. The second is, how do we prevent an LLM clinical arms race where we have greater automation, and in that initial honeymoon period, we're seeing reduced burnout, but then soon institutions are decreasing appointment lengths or increasing scheduling to make up for these benefits. And then in the end, we have sort of, we're running in place, like no net neutral long-term improvements. And how do we early on prevent that from happening? And then finally, this is a little more regulatory, but I think everyone should be thinking about this is, what is actually the appropriate model to regulate these LLM tools? Because they have features that are like a device, yes, but also things that are more like a human, of that we license individuals to do certain tasks and demonstrate competency. And it kind of lives in a hybrid world. And so I don't think we've really sorted that out. And with that, that's the end. I'll stop sharing. Oh. Let's see, stop share. Okay.
Great. Thank you all so much for that conversation. And I think now we're going to open up the discussion to the panelists and amongst the panelists themselves. And during that segment, ask and encourage all of you to send your questions into the chat, which I'll keep an eye on. And then for the last 10 minutes will be for those who wish to ask their questions in person by raising their Zoom hand.
I can, while we're waiting for, thanks, Kate, while we're waiting for sort of questions to pop in. And actually, I thought we could answer the first question that was asked by Marie. Do health systems charge or get reimbursed for responding to in-basket messages? Because I think Anna answered the question regarding like the AI, but I also wanted to answer the question of just in general, this is a larger problem outside AI in the sense that right now, in general, most systems do not charge for responding to in-basket messages. There are some pilots going on across the country where some health systems are charging for it. It's actually a little bit convoluted to set that up because, as you might imagine, you have to factor in insurance and co-pays and things like that. But that is an open question. Should health systems, freely respond to email questions and in-basket, or should they be charged? And I think we're still learning what might be the best practice there. And I don't know if Anna or Katie had other comments on that.
Yeah, at our organizations, we do not necessarily at this time charge for reviewing of in-basket messages, but I know that some of our colleagues do across the country. I think I did have a meeting with Epic today regarding the clinical summaries that Catherine mentioned, but it's also in those prompts of summarizing messages for providers. Any kind of prompting right now there is a cost to the organization as you turn those on. Some it's pretty significant if you think about if you have 6 million ambulatory visits per year, and even if they're a dime or a quarter or some $1, it will start adding up as we add these potential new features, and ultimately that's the cost of technology per an organization, but it'll get added to the healthcare costs.
Yeah, I thought that just building on that, Anna, and maybe building on something Katie had, where many of these interventions we're doing to help improve experience, either experience for the clinicians, cut down on the time they're on the EHR, or improve the patient experience. And I think Katie raised the real concern, and it's happening in some areas where these tools will actually be used to have our clinicians see more patients. And I think we've worked hard, at least with our pilots that we're doing so far, not to make that a condition of these tools. So we really do want these tools to improve experience. We think that's a big concern. And we're looking for other ways that there could be ROI, such as could these tools help with billing codes, maximizing the use of billing codes, et cetera. That creates a different type of arms race, potentially with insurers and CMS. But so there's always a trade-off. But at least for some of these initial tools, we're trying to not put the onus back on the providers and really try to improve the experience. But I think you nicely summarized a real fear of, what could be the other implications of these tools.
And we actually have a question that was put to me in the chat. I'm going to relay it out. It sort of relates to patients, which is, are there ongoing studies of patient outcomes related to the use of AI? And it wasn't pitched to any one of you in particular, so I think any one of our speakers can pick up the question.
We are studying, probably not as formal, but there are studies and publication, regarding the clinical imaging ones that I would mention. There are studies, they're at the early stages, but we do have researcher participating in those studies. Preliminary studies are patients, they like to get the results faster. And it's just about conversation, better patient experience, but we're studying as early some of them haven't been published yet necessarily. I do want to touch base on one of the things that Katie mentioned regarding the MyChart results and regarding what was shared regarding potential oncology. So Epic does have a new functionality where patients can say whether or not they want certain sensitive results. It's available now in a new upgrade. However, there is controversy among providers whether they want to allow patients to make those changes, because they're afraid that you won't be able to turn it back on and off, and people don't know who has it on. But it is something that Penn Medicine did push for, because to your point regarding sensitivity information, if it's released on a Friday afternoon and a provider is not there, we were very sensitive not having that conversation in a timely manner. But interesting, the listserv of providers, when it was released, there was mixed opinion on if people embrace that functionality because of the Cures Act and the regulatory requirements of sharing information.
That's really interesting and helpful to understand. And I think, yeah, it just underscores, nature abhors a vacuum. And so I think, we talk about these clinically adjacent things, like whether someone has toggled on or off that Epic module, if they're getting these results and they've got a couple days before they can reach their referring provider, and in desperation, they now are able to put them into ChatGPT and say, what does this mean on this brain MRI and things like that. And I know people left and right that are doing that. And it's a challenge, because we also know all the cases before patients had those results that there were diagnoses missed. So there's no easy answer. But I think we should be aware this may be where it's going.
Yeah, I got my, I'll share personal experience. I got my cholesterol results yesterday and I see my provider on Monday, and I was blown away. It wasn't as good as I expected. And I was like freaking out to my husband. I said, oh my God, my LDL is really higher than I thought. And I am running a marathon on Sunday. And I'm like, I am in good shape. How in the world is my LDL elevated? And I was really caught off guard. And he said, don't panic, talk to the provider. It may just be just one result. So anyway, but I was just panicking on a cholesterol level. Can you imagine if it was oncology result?
This is one, I'll just chime in here because I agree. I think the concept of making like the medical records belong to the patient, they should be available to the patient. I think this is one where I wish there was more practical pragmaticism in these rules. There's a compromise here, which is what we used to do in our health system, which was to just delay the results by like 3 or 4 days, which gives for sensitive results, which then like not for things like a CBC or a chemistry panel, but for things like an HIV test or a pathology result. And so you still make the results available, but you give enough time to be informed. And, we we had all our policy experts and legal experts review the, the regulations, and we concluded we had to release the results right away. And so that's what we're doing. So there's a trade-off as we're seeing here. I wish we could find the compromise, because I do think there's a genuine compromise that meets the requirements of making this stuff available, but helps protect against some of these unfortunate cases where someone finds out about a devastating diagnosis without being, informed appropriately by a clinician. So this is an area where I still wish we could go back and modify. I think there's an easy fix here.
And
I
it's
think you're
incumbent
right.
upon us to push for that, because it's just a law and regulate. It can be changed. It's not easy, but yeah, we should think of those things as a moving target. It's a great point.
Yeah, I'd just like to comment. I worked at Beth Israel when Tom Del Banco introduced that whole concept of the chart belongs to the patient, and began, testing that, et cetera. But who would have, I'm sure he never would have thought of the issue around patients putting those results into GPT or getting those results ahead of time. Do you know what I mean? I mean, you've really pointed out amazing things that I never would have thought of. I really wouldn't have. So.
I think maybe we have time for one or two more questions. I know this is such a full talk. My brain is like, I know I have questions. I just don't know what the questions are, because it's such a.
I've never had a person ask me, will this be posted? Because it was fabulous. And I think it's like, I mean, the presenters were amazing. I mean, the coordination and the innovation and the data, the information that you presented was like invaluable and certainly eye-opening. And yes, this recording will be posted on the President's Lecture Series site. And I think you're right. I think there's so much to think about. That's what Judith Pelletier is saying. But I just wanted to make one other comment that had come across in my email just the other day. And it was that there were nurses, and I won't name the large healthcare system, but it was a very large healthcare system. And the nurses were unionized, and they were successful in getting in having it that all nurses must be, or nursing as a profession must be involved as AI initiatives are taken on in the hospital. And that really is consistent with what you all were saying, is that the nurses, all the professionals, people that are in using this have to be involved as it's being developed. And I also had no idea the extent to which the studies are going on and what they're looking at, and that you're really using AI to help reduce burnout, which, as you pointed out, is huge. So those are just my comments.
I'll throw in one question, just because we are Regis College, and there are, I know, some students on this, as well as faculty who are teaching. In your thinking around all the various issues you brought up, where do you see the role of educators in kind of preparing the sort of next generation of healthcare professionals in entering into this new world? Like, where do you see that going? I mean, maybe it's a big blank canvas, I don't know, but I'm sort of curious where you see kind of where higher ed can kind of help guide in some of the our new students moving into these clinical practices and becoming professionals.
I'm happy to offer initial thoughts, and I'm sure my colleagues will want to jump in. But first, I think higher ed has a major role to play here. I think you guys are clearly a leader by even hosting a talk like this. But my sense is that AI needs to be a standard curriculum, probably starting in high school, maybe even earlier, so that people are trained in appropriate use of these tools. I think of this much like even laboratory testing, right? When we're learned about laboratory testing, you learn about sensitivity and specificity and how to interpret results. And I think we need to do the same around AI tools, and really teach our clinicians how to use these tools, what questions to ask, how to be a critical thinker in applying and using AI. And then I would also add, there may be some folks we're training, and we need more informaticians like Anna, who are both trained in clinical medicine and nursing, but also trained in technology, and can be the bridge between our technical teams and our developers building products and rolling out systems and the clinicians to make sure their needs are met. And then we need researchers and others to help us validate. So I think there's rich opportunities, and absolutely need to incorporate this into education as soon as possible.
Yeah, I would just say I fully second that. You know, I'm biased probably because I've written about that. We were saying exactly that basically we need to adapt, which we didn't do a good job with teaching clinicians how to interpret laboratory tests, extend that to, you know, predictive AI. Generative AI is a whole new can of worms that I think adds another layer of complexity. And I know it's different than nursing students, but applies anyway. I was teaching med students this morning, and it makes me really frustrated every year that I teach them that there's such an emphasis on memorization in medical school, for example. And I understand that, but having come from a legal profession and where the emphasis is on critical thinking, and I cannot echo Adam's point enough that I think that teaching critical thinking and reasoning will be so important, because increasingly some of these tools will be able to give you that information. And especially if they're listening, you don't even have to remember the symptoms of the mnemonic that goes together for a condition. It may be able to offer you that. The emphasis is going to be, okay, what do you do with that information? You can't run every test. You have to make decisions. And how do you critically reason through it? And so that's the skills that I really hope are increasingly emphasized in future clinicians.
I just will add on, definitely the student early years, as Adam mentioned, definitely. But we also need to educate the nurses, the nurse leaders today, that's within the hospitals, and for nurses in particular, because if you looked at some of the examples, it was about providers starting in the provider space. There's a lot there, but nursing needs to have a voice at the table. They are the largest workforce in the country. So some, as nurse leaders get educated, they need to empower their nurses to be at the table and participate, and make time for them to participate. You know, providers find the time to participate, and that's why they're always innovating. Nurses need to do that also within the healthcare system, but it does begin as a student to get that educated, and it's just a continuously growing, evolving field.
Well, we're almost at time, and I think Penny is just moving to put the link. For
I
the
am trying
in the
desperately to
chat.
do this. This is another thing that my graduate assistant would do. So
So I'm going
just
to talk
hang in there.
slowly here for as we wrap.
It's
I
coming.
so I absolutely want to thank our guests for spending time with us this evening, and just giving us so much to think about. And I also want to thank Harvard Pilgrim Health for their sponsorship. And of course, to all of you for being here and staying engaging with this conversation. I'm sure I'll come up with all sorts of questions, which I will send to Penny tomorrow, which she can maybe send to the panelists, because this is just for not being a non-expert in this, but in sort of some of the higher education things we've been thinking about and wrestling with. It is seeing the potential of where AI can go, as Dr. Landman showed, even with the kind of guardrails and other pieces, caveats that were part, was really was fascinating. So really appreciate it. And now
we can
Yep.
let them go. And I copied this, and I'm going to
put the link in the chat.
I'm going to try and paste it in the chat, and it should work. There we are.
Not seeing it, Penny.
Oh, that's because I didn't send it.
Well, there you go. There it is. Now, all of you who need your CEUs or credit, please do complete the survey. But also, if you don't need any of that, we still entreat you to do the survey, because it will help improve the future of this lecture series. So very much appreciate you doing that. Thank you again, everyone. We'll leave this up for a little bit just to make sure people have access to the link.
The
but
link stays on
otherwise,
there till at least a quarter of.
right. So
So you
otherwise, thanks.
copy it and you can fill it out.
Yeah.
And I did have a slide to share that said thank you to our wonderful speakers, but of course I can't get it.
That's
But-
okay. You just verbally thanked them. So we're
Yes, I mean, they were amazing. They really were. It was really a pleasure. And Mary Scanlon just said, thank you, a lot to think about, and it's true. So our guest speakers are allowed to leave now. You do not have to fill out an evaluation.
Thank you. Thank you for having us.
Oh, thank you so
Thank you.
much for
Thank
doing
you.
it.
Have a
Bye.
great evening.